Our next speaker is Dr. Kosali Simon. Kosali is a professor at the School of Public Affairs and Environmental Design at University of Indiana. Now, as a health economist, all health economists know Kosali very well for her work in the health insurance sector. She has published extensively on both the public and private sides of health insurance. And that research, I think, naturally led to her interest in what she's talking about today in terms of prescription drugs, in part because of what went on in terms of Medicare and Medicare Part D. And she'll talk more about that. And with that, I'll just hand it over to you.
Thank you very much, Vivian, for inviting me. I'm delighted to be here as part of this conference and excited to be talking about this sector to which we look for panaceas, for amazing cures, and looking at how this sector fits in with the overhaul of the healthcare sector that happens in the Affordable Care Act is the focus of my presentation. But I'm going to be talking first about the background in this sector by laying out the landscape of where we're at right now and also how things have progressed. Looking forward, what are some of the things that we can anticipate as being trends that are happening anyway, and how would healthcare reform affect those? I am going to then spend some time on the specific features in the Affordable Care Act that relate to prescription drugs, and think about future trajectories from there. So to start with, this slide shows information about where we're spending our healthcare dollars. It's something that the Centers for Medicaid and Medicare track throughout in consistent ways, and the latest information shows that we are spending about 12% of our healthcare dollars in prescription medications. Now, two things to note here. One is that the bulk here, the largest sector, is still in hospitals. It has been declining a lot, but it still continues to be where we spend 36% of the healthcare spending. Prescription drugs have been increasing over time, and in the next slide I'm going to look at what the trend has been for prescription drugs specifically. So right now we're spending about $307 billion a year on prescription drugs, and the next slide shows what that growth has been. So the red line there shows the growth rate annually from one year to the next. We're no longer in the era where this was double-digit rates. In the early 2000s, we were really concerned about what would happen to prescription drug spending because we kept seeing year-to-year increases that were just so high compared to spending in other sectors and compared to what was happening to GDP. So we've come a long way from where that is. Right now, we're only at about 3% or so. The latest numbers are, as we know, in all areas we're spending less, but can't really extrapolate from that alone because of the recession's impact on spending in all sectors. But even before the recession hit, we've been coming down in how much we're spending on prescription drugs. As you can see, there is that blip in 2006 when Medicare Part D was introduced. But if we go on to look now, peeling behind what's in this spending, we see some signs of what we might be able to anticipate happening in the future. So looking at which particular drugs are responsible for what are the big spending categories in terms of therapeutic classes, oncology drugs are up there right now. So these numbers are going to embody what's happening in medical technology as well as in things that are affected by regulation, patent expiration and generic entry. We're no longer spending the most amount on statins, and we're seeing this in the growth of the oncology drugs and specialty classes. If you look more specifically at what particular drugs we're spending a lot on, Lipitor still is at the top, and we can see that it's kind of held steady for now, but there's important changes happening in laws that are going to affect that in patent expiration. So spending on prescription drugs is concentrated in some big blockbuster drugs. There's also a concentration of manufacturers in this industry. This slide shows the aggregations that have happened through mergers and acquisitions, leading to companies that now several companies having more than 5% of the market share. So you can see that throughout time we've gotten more concentrated manufacturers over here. So now who's paying for these prescription drugs? Private insurance, even after Medicare Part D was introduced, private insurers still are paying the majority of the share here, and this, even though Part D is administered through private insurers, counts Medicare as spending for that group. So 60% is private third-party insurers. You can see then this decline in the blue line is showing what happens to out-of-pocket spending. Out-of-pocket spending, which was close to 40% in the mid-1990s, started to decrease as more private insurers started adding prescription drugs to their insurance benefits. And then starting in 2006, we see Medicare start to cover prescription drugs. And at the same time, there's this drop in Medicaid because of the dual eligible population. So the population that Medicaid covered through prescription drugs for, that then in 2006 got transferred to the Part D program, creates that shift there. And then you can also see there's this decline in the private insurance payments over there. But still, this is quite indicative of what we think is going to stay. Now, when we look at this recent slowdown in the spending growth, it's important to then think of what the causes for that are in order to understand, is this a decline that's going to continue, or what might, where would prescription drugs fit in terms of where we're spending our money in 20, 30 years down the road. Two of the things we start to look at when we unbundle what the spending includes is quantities and prices. So first, looking at quantities, this slide shows you the volume of prescriptions that are being consumed from 2001 to 2010. There too, there are declining growth rates, again an increase in 2006, but overall increase in quantities. So over this time period, we expect that there'll be an increase in the number of prescriptions used, simply say for population growth. The population's growing close to about 10% of this time period, and there's a growth of the quantity of prescription drugs that's more like a third. So there's a lot that's growing, even though the rate of growth has been slower. But the bigger change is coming from what's happening with the use of generic drugs. So this is a really striking figure, I think, that we are consuming 75% generic drugs now in the U.S. So that's come a long way. And it's also, I didn't put up any international comparisons here, but it is a way in which we differ from other countries too. We are using more generics. Now I'm going to unpackage the last few years to look at changes from year to year and see how much there has been an increase just even in the most recent years. So just going from 2008 to 2009, there's something like a 12% increase there. So it's been a very noticeable trend. And as generic entry happens, there's the brand name that loses sales, but you can see how much quicker that's happening over time. So this slide shows that when generics start to enter, once patent expiration happens, when the first generic enters, they lower price, but they have a period of they have a certain period during which they're the only generic, so they don't lower price by that much. They'll lower price by almost half. But over time, very quickly, when the next generics start entering, the price will go down to about a fifth pretty quickly. And that's what this shows, is that the market share drops really, really rapidly, and that the rate at which it's been dropping has increased over time. So the more steep graphs, the more steep lines are happening now as opposed to flatter lines earlier. Just to take an example, I looked at the price of Zocor today and saw that if you buy a bottle of 30 pills of 5 milligrams each, if you buy Simvastatin, that's about $18, and if you buy the branded Zocor, it's close to $80. So this is a drug that had the first generic entered in the summer of 2006, and quite quickly the prices stabilized to these levels. There are a number of drugs that are going to face patent expiration soon. Lots of blockbuster drugs, including, as we know, Lipitor is currently undergoing that process, and then beyond 2015 there are several, but many of the ones that have been large blockbuster drugs are facing patent expiration and generic entry. And if what we've seen in the past is a trend, then we know that this is just going to continue to make the percentage of medications we use that are generic higher, and the per prescription prices therefore lower. But there's the exit of patented drugs. Then we also have to keep track of what's coming in. Since patent expiration is just a known factor that's going to happen, if we had a pipeline that was really steady, that wouldn't really matter in the sense that a new blockbuster drug would replace the drug that's going out. But what we've seen is this decline in the number of new molecular entities that are gaining approval. At the same time, this rise in the research and development expenditures. So just in 2010 alone, there was only 21 new molecular entities that were approved. Of those, 3 were biologics. But compare it to a year like on this graph, I think it's 1997, when there were over 50 being approved. So health insurers have also been active in thinking about promoting the use of lower cost drugs, in particular the generics, and they've done that through the cost sharing mechanisms they've got at their disposal. Because otherwise, if there are alternative drugs that are pharmaceutically equivalent, yet there's a lot of marketing and perception behind brand names that are thought to be better. Unless the consumers faced an incentive change, we don't think that these changes that are happening in the legal status and in the marketplace would necessarily translate to rates of use that are different. But what this slide shows is that health insurance companies have been really active in the use of formulary management techniques like cost sharing into tiers that separate the drugs that are going to have no competitive generics available. So if you now as a consumer want to keep buying a branded drug when a generic exists, you're going to have to be willing to pay a lot more out of pocket. Health insurance plans have also been active in negotiating for rebates with manufacturers. Pharmacy benefit managers have negotiated such that even just in the private sector, going from getting an average discount of about 8% in 2002, the average percents are more like 14% now. And then Part D, which does not, the government doesn't negotiate under Part D, but manufacturers and private insurance companies can still get rebates. That's estimated to be about 19%. But where we get the largest discount is on Medicaid, of course. So on average, it's estimated that it's about a 45% discount through purchases through Medicaid. Now, an area of concern in prescription drugs sector is how are these drugs being portrayed to individuals? How is the persistence of brand names? Why is it that even when there's a generic brand name, still are being purchased? And understanding the role of advertising is really important here, because we are pretty unique as a nation in allowing manufacturers to advertise directly to consumers. When you actually look at the numbers, a lot of promotion is still happening to physicians. The amount that's being advertised directly to consumers is a fairly small slice of this whole endeavor, yet it is a major concern, because we believe that while the physician has all the information in order to make an informed judgment, we're really concerned about how patients are being provided with information through advertising that might affect their choice of medication. So even there, though, there's been a decline lately in the amount that's being spent direct to consumers to advertise these drugs. But this continues to be an area of concern in how we allow these kinds of advertising to take place. For example, whether we have enough of a fair balance between risks and benefits. Really concerned about drug safety and tying that to how these drugs are initially advertised when they're put. So this brings us now to thinking of how the Affordable Care Act and the features within it relating to this sector might have an impact. So I'm going to start just by pointing out that anything that is in the Affordable Care Act that increases use of healthcare services would probably apply to prescription drugs, because we know that that's such a fundamental part of delivering healthcare. So we just can look at numbers here. How many newly insured people do we anticipate this law will affect? So numbers by the Congressional Budget Office are, say, 32 million. That's a large number of people who are now going to face a decreased out-of-pocket costs for prescription drugs relative to being uninsured. And just couldn't help here, just draw some lines and show demand curve. As we expect, when you think of price and quantity relationships, the demand curve is sloped such that when price is reduced, the marginal out-of-pocket costs for the patient, we expect they will consume more. Now, research shows we're not really sure just how much that will have an effect and for different populations, but we expect, especially because these newly insured are those with lower incomes, that there will be a substantial impact in terms of increases in demand for prescription drugs. In particular, about half of the newly insured are going to be insured through Medicaid. Now, this has a different impact when you think of what it does to the supply side, that is, the price that the manufacturers will get because of the rebates, as opposed to what happens on the demand side, that is, what sort of copay structures will the newly insured have. On the demand side, then the consumers being insured by this program, there are very low copays in effect. So it's not going to be the kind of copay structure we showed earlier, where you have this very high rates of copays for the more expensive drugs. But on the other hand, there are very steep discounts on what is going to be paid out. So that's something to keep in mind when thinking of how many newly insured and what will that mean as increased demand for this sector. There are also going to be rebates that are extended through the Medicaid through the Affordable Care Act, and an extension of these reimbursements to managed care, and an expansion of the program, the Federal Supply Schedule, that allows certain other, like the Department of Defense, buying drugs at different discounts. So there's changes happening in what's going to be as a rebate for prescription drugs. But the part about the Affordable Care Act that's probably received the most amount of attention related to prescription drugs is on Medicare Part D and the closing of the donut hole, this extremely unpopular feature of the MMA, that the legislation that set up the Medicare prescription drug program was closed under the Affordable Care Act. And we have to think about what that does and why that was initially in there. So going back to the discussions around the passage of the Medicare Part D legislation, it was thought that in order for the budget numbers to work out, in order for there not to be a big increase in government spending, that there had to be this coverage gap, in which case you're going to be spending all of the costs in a certain area. Now, we have in the ACA provisions to close this gap through the coverage of from the manufacturers actually paying for it for the brand name. So it's not that we just extended the features we didn't want to earlier. So I'm going to show two slides that examine how this feature affects what the benefit schedule looks like, and these should be thought of as by 2020, when all the features of that closing of the donut hole are administered. So in the darker blue are the parts that the beneficiary pays, and in light blue are the parts that the plan pays, and in some cases what the government will pay for. So the first amount of money you use in prescription drugs under Medicare Part D, you're responsible for it under the deductible. Then the insurance structure kicks in, by which you pay 25% and the plan pays the 75%. After that, you get into the donut hole where you pay the entire amount, and once you've come to a total of a certain amount, you get into the catastrophic region where you pay only 5%, the plan pays 15%, and Medicare pays the rest. That's the structure that would be in place if the donut hole provision was not in the Affordable Care Act. As a result of having that donut hole closing provision, instead we have this picture where now the amount of the darker blue area, the amount the consumer was paying, is reduced a lot, because that 25% coinsurance rate now extends all the way to the point at which you're then in the catastrophic region and paying only 5%. But the way in which it's done and the timing of it are interesting, because it's that we are asking prescription manufacturers to cover 50% of this, and that the plan would pay 25% of it. So the provisions are that that right away, the beneficiaries who reached the donut hole got $250 rebate checks, and these started in June of 2010. Those started being mailed out, and according to recent estimates from the Department of Health and Human Services, there were close to 4 million of these checks that were mailed out. In the coming years, there's this 50%. So right now, the 50% discount on brand name drugs is in effect in that region of spending, and then the government adds a gradual subsidy as well, so that eventually we'd be having 75% of it covered, 25% cost sharing. Now the generic use of generics in the donut hole will also be subsidized through another gradual change, and these next slides will show kind of the time frame of how this happens. So for brand name drugs, this is the way by which that dark blue amount gets reduced over the next few years, and the beneficiary copays go down to 25%. For the generics, this is the way that it it happens. So that's a pretty notable feature. There are right now, there are 90% of Medicare beneficiaries are covered by prescription drug insurance. Only about 5 million beneficiaries are without it, and there are a substantial number of a few million who enter into the donut hole each year. So that's a big feature. There are other parts of Medicare Part D that are changed in the Affordable Care Act. There's the subsidy that is given to employers to provide retiree coverage that includes prescription drugs. That subsidy still exists and continues, but employers are no longer going to be able to deduct it from the taxes they pay. There are reductions in payments to Medicare Advantage plans, and this is sort of notable because when we've added prescription drugs to Medicare Part D in the traditional form of Medicare, we added it as a separate entity. So to the extent that there are ways that formularies can be used to manage what medication can do, what surgeries and other kinds of care could do, there isn't an incentive structure built in right now that can be taken advantage of, except in the case of combined plans like that. So those are sort of things that they are not really related to prescription drugs, but can have implications on the use of formularies. There is a provision that preventive services that will be defined and are then defined by the Preventive Service Task Force will receive 0 copays. And this is for private insurers, as long as they're not grandfathered plans. There are certain plans that are exempt, and those reduce over time, and for Medicaid and Medicare. So there are some specific classes to watch for, and in particular the one at the end. It was not part of the U.S. the Preventive Service Task Force, but the Institute of Medicine then issued some guidelines saying that preventive care services for women should be included as part of this provision. This summer, the Department of Health and Human Services issued regulations then to include them, and that includes prescription drugs for contraception. This is a big market, and it's one I'm now going to show a slide which I created just this morning. So, some of these things in the law, you wonder, will anyone really know about these features? On the plane yesterday, I was sitting next to somebody who was reading a magazine, and she opened the page and said, "Look," and I said, "Oh my gosh, I have to take a picture of that for my slide." So this is where this comes from. These are it's going to be interesting to see what happens in a market where now the law says copays will be 0, so we can't be using this shifting of tiering in order to manage growth of spending. Then there are these fees that are charged of sectors. The pharmaceutical sector is not exempt. It also has its schedule of fees, and this is what it looks like over time. There are other features that are relevant, and this also now, this first bullet point here is looking to the future. What do we think is going to happen with biologic drugs? So here's an area where, if we think to the past, what's happened is that blockbuster medications that were leading to cost growth being really high, as they start getting off patent, we have generic entry, and we see a big change in the way things were looking. Now, as we think of biologics going forward, these are drugs that are really hard to manufacture generically, because it's not the same as taking a chemical compound and saying, here it is, it's the identical chemical compound. Trying to establish equivalence is going to be very difficult. So the Affordable Care Act has features in it that define the period of patent exclusivity and processes for how bioequivalence would be followed through. There are other provisions in the Affordable Care Act that have to do with whether over-the-counter medications will be included in flexible spending account amounts. So it's tax subsidies that were used for out-of-pocket spending. Those are reducing a lot. And then not looking into the future, there's, as a lot of healthcare IT is adopted, there are going to be changes in how prescriptions are in e-prescribing. But also important to keep in mind is what didn't happen to the pharmaceutical sector under the Affordable Care Act, and whether Medicare was going to negotiate prescription drug prices directly with manufacturers is a big thing that was being discussed but didn't get included, and also keeping off the table some other things that could have been cut. So I think new technology development, adoption in reaction to new coverage is interesting to track. Advertising strategies aimed at this new population, pricing, how will these taxes actually work? Will they get passed on through higher prices? And formulary designs, and looking into the future, then really paying attention to the biologic sector, I think is very important, because these are difficult drugs to develop. They are what's coming down the pipeline. They are very expensive to establish generic equivalents of. So it's not that we can expect what trends we saw in the past for blockbusters come and then they are transferred to generic is likely to happen. And this means we have then very difficult questions ahead of us on, in the same lines that Dr. Chandra was pointing to, when we are able to deliver medicine that is phenomenal in its impact, or in its promise, I should say, in those cases, we have to make decisions about whether we're going to pay for them. And that's really difficult because we've got these, we know that if correctly targeted, a small amount of spending in the use of aspirin or some low-level technology can have really huge impacts. And then we've got amazing drugs and technologies that cost a huge amount of money. It then becomes a political decision or an ethical, a society's decision about how well or which populations, how we're going to cover them. So I think in the pharmaceutical sector too, these are all going to be important questions that aren't going to go away easily. Thank you.
My name is Carolyn Belk, and thank you very much for being here. One of the most immediate concerns are the looming drug shortages and the debate about whether that is a scam by the pharmaceutical industries to drive up cost, what the FDA can do about that, and how that's going to change the dynamic and discussion of trying to bend healthcare costs down. Have you looked at that issue, or is that something you're studying now?
It's not an issue that I've looked at. In fact, I'm going to look to the panel of experts and see maybe one of them might have. I'm not aware of what it is that would be an easy solution to problems of potential shortages, except that prices adjust.
Yeah, I think what you're referring to is the shortage of oncology drugs, and that's been definitely a concern over the Texas Medical Center. The only analogy that I can point to is what we dealt with several years ago in terms of shortages of vaccines. And at that point, we did need federal government intervention, that they did had to come in. In that case, it's a little bit different because there were strong externalities. We want to vaccinate the whole population, otherwise we're going to have a public health problem. And I think, though, perhaps, we would like to have government intervention in this case, and it's probably going to take some lobbying on the part of cancer groups in order to have that type of strong reaction, because the federal government is still providing subsidies for vaccines, and it'll be interesting to see whether that happens for oncology drugs.
That also is then it's a sort of a supply process that can't be increased immediately like we could with manufacturing of pills. We just can have the production process increase, but biologics will take a long time to develop these proteins and so on.
I'm just curious if you think the new ACO rules that came out from CMS regarding marketing are going to have any impact on some of the marketing discussion that was earlier in your presentation about directly to the consumer and or physician.
I think there's been for a long time this concern about whether we should restrict the way that advertising happens to consumers, because other than New Zealand, we're the only developed country that allows that. And then when we have had so many safety-based recalls of prescription drugs, that becomes even more of a concern. Did we encourage the use of these medications that then result in unknown? So I'm not familiar with if there's a specific regulation within the ACO law that restricts direct-to-consumer advertising. But again, if
just marketing, generally speaking, because the finalized ACO rule from CMS and the MSSRP program, it relates to marketing, and I was just curious.
Is it something that stops the targeting of consumers?
He's more
I don't think it's
yeah, I think it's just generally you have to submit beforehand, and I was just curious if you looked at that.
I've done research that has looked at the content of advertising and whether there are the guidelines about fair balance between risks and benefits, and it's such a difficult area in which to regulate, because how do you monitor the tone or the font size, and how do you, if you were to require ads to be submitted ahead of time, that really adds a lot of administrative cost also. So I say just that what I've looked at is by doing content analysis of advertising, that's really hard to see how a regulation could be written that exactly determines the way the ads look.
I'm really glad that you talked about the generic part of it. I had a personal experience. I was taking Prozac, and it became generic, and I was, the price went down substantially, and I was saving so much money, I wasn't depressed anymore.
There we have it. The solution is in the price.
I've been wanting to say that for years. Wanted to ask you, Medicare Part D, you talked about prescription drugs being a relatively small part of the cost of medical care. But Medicare Part D is 75% paid by the consumer and 25% by the government, and there is no trust fund. It's all pay as you go. Do you have any kind of figures on what percentage of Medicare spending Medicare Part D will be, particularly with this donut hole being closed, over, percentage of Medicare between A, B, C, and D?
All right, now that's a good question now. So by law, 24.5% of the cost of the program is going to be paid by the beneficiary, and the rest subsidized by the government. And then there's the population of the population of the low-income subsidy population. Then they get full coverage, and that population didn't have the donut hole even to begin with. What this does to both amounts of spending in the future and incentives for the development of new drugs that are brand name is really important, I think, to think of. It's not, if we just take a look at what people spent in an era where they faced high cost sharing and then thought that's what's going to be now added to the total amount of cost, that's sort of a very short runway to look at it, because we know there's going to be incentives that are changed as people realize that now going into the donut hole isn't this huge catastrophe of cost that it was before. The whole year's medication therapies, choices that physicians and patients make may alter. And there's evidence from work that Neeraj Sood and his co-authors have done, have looked at what that incentive translates to down the pipeline, and they saw that after the passage of Medicare Part D, innovations that are targeting drugs in therapeutic classes taken by the elderly really responded in using methods that Professor Duggan and others have used. So that's something to watch for, what this means for Medicare down the line when we're closing this feature that would have increased price responsiveness and care in what medications were prescribed.
You showed this figure about the number of sort of new medical entities or that sort of were coming out each year, and it's definitely lower than it was in the past, even more when you account for sort of the expected magnitude of the drugs. And there's, I've heard a lot of chatter that is largely driven by policy changes that perhaps, and I'm just curious, I don't have a particular view on it, that maybe the FDA now is a little tighter than they have been in the past about approving drugs. And there's it's all trade-offs, I guess, but I'm curious to see how important you think the FDA and sort of other regulatory agencies will be in sort of shepherding this industry to a good outcome, because how stringent you are can affect how many medications come out, but maybe it's good to be stringent to prevent things like the Vioxx or what have you. Yeah.
Right. Yes. There's so much risk involved in the R&D process that when you start, you have to put in the money early, and then you just have to see where this process of discovery takes you. And when those initial decisions about investing money are driven by foreseen probabilities of whether you'll get approval, it's hard to know what that does to the development of new things that would have been unexpected in the process, right? Just the fact that there was so much money being put into research and development led to drugs that were discovered that weren't really the initial target. So if we think that there's a lot of concern being paid to any downside risks that a drug would have, or that the therapeutic, just how much less of a Me Too drug this is going to be is important, then that has important incentive effects that are felt throughout the development pipeline.
Dr. Simon, could you talk a little bit more about the taxes and the fees that are going to be levied on the pharmaceutical companies? You alluded to this issue. I'm just wondering, is this going to be a cost that's going to be completely passed on to consumers, or is it going to change the level of innovation amongst pharmaceutical companies because they're not going to have as many resources to conduct R&D?
Right, so there's these fees, and I also didn't mention the part that was is the fee on the medical devices sector, which also is relevant to thinking broadly about these innovations. So the typical analysis, thinking about who really pays these taxes, are take into account that by law it's easy to say that a certain business sector will pay them, but we have to consider what actually then that means for the consumer. If the market is such, if there's many competitors, then and their profits, then we think that it's going to play out in a different way than when there's this concentrated market. So as an analogy, think of the amounts that the tobacco industry was required to pay under the Master Settlement Agreement in 1997. You thought of those as really taxes. It was good in that we felt like we were taxing the cigarette manufacturers. But then when analysis is done later and it shows what that does to cigarette prices and who actually buys cigarettes, the incidence of those taxes is very different. So in a similar way, when thinking about what are the therapeutic markets in which there aren't as many competitors, in which these taxes could be passed on through higher prices, it's not so clear exactly who's paying.
You don't want to make a statement on what you think is going to happen?
I think it would. I mean, yeah, I think the panel would be having even better guesses than I would. So yeah, it would just be speculative on my part. I haven't seen any analysis done yet, but not to say that it doesn't exist. Somebody's got to have thought of this question or.
Thank you. Kosely, I was just curious, in the calculations folks have done trying to estimate the cost or utilization impacts of the pharmacy benefit changes of the ACA, have any of those included offset effects? We know that there's been some research that looked at when, say, cost sharing went up for pharmaceuticals for the privately insured, there were offsets in use of ambulatory care, that kind of thing. I don't know if research has looked at the opposite direction, but I'm just curious whether that's been taken into account in these kinds of calculations.
I'm not sure if they have, but those kinds of offsets are really important to consider. That we can't think of this, what changes in pharmacy, what changes in use of medications then should be looked through as this has important implications for the use of inpatient care, right? That's what's sort of deceiving by looking at that first slide I showed of prescription medications are only 12%. But the whole reason that we pay attention to whether prescription drugs were covered under Medicare Part D was because we felt this was really inefficient, that we covered under Medicare these really expensive, invasive services with no limits, and with no limits to what we would cover, and yet we didn't cover the medications that could have been an alternative for them. So studies like the work you've been doing looking at what kind of offsets there are really important for knowing what to expect. But to answer the question, I don't know the extent to which and which estimates were used, but those are important. Thank you very much.
Thanks very much, Kosely. This was information that I have not seen in any of the public outlets or research outlets, so it was very helpful to hear it, and maybe sort of a bright spot in terms of controlling healthcare spending. So we've got time for a break now, and we're in a good position because we're actually ahead of schedule. We're going to meet back here at 11 o'clock and continue with the next speaker.